Welcome to This Explainer. Today, we're going to bridge that critical gap between a clinician's bedside discharge and the back-end compliance standards for coding and documentation integrity. If you've ever wondered how a doctor's final orders actually translate into a fully compliant coded medical record, well, you're in exactly the right place. We are going to break down the entire anatomy of a hospital discharge, step by step.
Okay, here's our roadmap for today. We'll be looking at structuring proper discharge orders, discharge summary architecture, leaving AMA versus elopement, UHDDS, and final coding, and finally, retrospective queries and validation.
Let's dive into Part 1, Structuring Proper Discharge Orders, the Bedside Foundation.
So we start our journey right at the bedside with the discharge orders. These really aren't just administrative checkboxes. They serve as the absolute clinical foundation for a safe, coordinated transition of care as the patient leaves the hospital. There are 5 core components every single proper discharge order must have. And the crucial point here? Absolute specificity. Take activity level, for instance. You want to completely avoid vague instructions like avoid heavy lifting. The patient doesn't know what heavy means to you, right? Instead, you've got to document specific limitations, like no lifting greater than 10 pounds, so they fully understand their parameters at home. The exact same goes for diet. Specify low sodium or low fat rather than just writing down a general recommendation.
Now, this specificity is absolutely critical during medication reconciliation. This is a massive patient safety process. It basically involves looking at what the patient took before admission and comparing it right alongside what was prescribed during their stay. By explicitly comparing these two lists, clinicians can stop dangerous drug interactions in their tracks. Ultimately, this whole process ensures the patient clearly understands what to start, stop, and continue taking at home, right down to the exact dosing and frequency.
Moving right along to Part 2, Discharge Summary Architecture, the complete narrative. Once those foundational orders are complete, the clinician has to construct the discharge summary. And let me be clear, this isn't optional. It's a mandatory legal document for literally any hospital stay lasting longer than 24 hours. It's essentially the whole story of the patient's hospitalization. As you can see, the architecture maps specific components to strict requirements. The absolute most critical narrative in here is the hospital course. It shouldn't just be a lazy copy-paste of daily notes. It needs to be a really thoughtful synthesis detailing the patient's daily progress, their treatments, and exactly how they responded to those treatments. And when you're documenting the patient's condition at discharge, please avoid those unhelpful single-word descriptions like stable or improved. Instead, explain precisely what milestones the patient has actually met. Document things like the patient is tolerating a regular diet, they've got adequate pain relief from oral meds, and they're ambulating unassisted. You want to paint a crystal clear clinical picture of why they are truly ready to go home.
All right, Part 3, Leaving AMA versus Elopement, Handling Unexpected Exits. But hey, what happens when the patient's journey doesn't follow our nice, neat script, and they just decide to leave the hospital unexpectedly? Well, documenting these scenarios correctly is a huge deal for both patient safety and your own legal protection. There is a stark legal and clinical difference between these two events. With an AMA discharge, you absolutely must assess the patient's capacity, meaning their actual ability to understand the risks of leaving. And you have to document explicit risk counseling, ideally using direct quotes from the patient about why they're refusing care. But with patient elopement, the patient simply vanishes without telling anyone. There's zero opportunity for counseling, so your documentation has to be purely factual. Just note exactly when and how the absence was discovered, without any guesswork or speculation.
Next up, Part 4, UHDDS and Final Coding, Translating Clinical to Administrative.
Okay, so the patient has formally left the building, which means we shift gears from the clinical side to the administrative side. This is where clinical documentation integrity, or CDI professionals, step in to apply the Uniform Hospital Discharge Dataset, or UHDDS rules, to the provider's narrative. A massive part of this translation process is differentiating these two concepts. The admitting diagnosis might literally just be a symptom that brought the patient in, like acute abdominal pain. But the final discharge diagnosis, that's what we know after all the tests and treatments are done, like, say, acute appendicitis. Making this distinction crystal clear in the documentation is absolutely essential for accurate coding and avoiding some really costly compliance headaches.
Another really key concept CDI specialists look for is present on admission, or POA. Figuring out exactly what was present at the exact moment of the admission order is so vital for accurate coding and quality reporting.
If the clinical documentation is a bit hazy on whether a condition, like pneumonia or an acute kidney injury, was already happening before admission or if it developed during the stay, the CDI specialist has to step in and get that clarified.
Which brings us to Part 5, Retrospective Queries and Validation, looking at the 2026 AIHIMA and ACDIS standards. So this is the final piece of the discharge puzzle, the retrospective query process. When documentation just isn't clear enough for coding, we have to go back and ask the provider for clarification. Think about it. How do we handle a scenario where an attending physician documents a really severe diagnosis, like acute respiratory failure, in the discharge summary, but the clinical indicators, like the lab work, the oxygen levels, and the imaging reports, they just don't seem to back it up at all? In these exact cases, CDS specialists issue what's called a clinical validation query. Under the 2026 standards, the golden rule is that these queries must strictly adhere to ethical boundaries. This means you have to present the clinical facts completely objectively. You have to entirely avoid any mention of financial impact, reimbursement, or quality penalties. And above all, you can never, ever steer the physician toward a desired answer.
So when do we actually send these? Well, there are precise, compliant triggers for when a query should be generated. It could be that explicit documentation is missing despite really strong clinical indicators, or maybe there's a glaring inconsistency between the attending physician and a consultant, or, like we just talked about, a diagnosis that completely lacks clinical evidence in the lab results. These triggers are here to ensure that the final medical record accurately reflects the patient's true acuity before that final bill ever drops.
And formatting really matters here, folks. Multiple choice is best for clinical validation, while a simple yes-no is great for clarifying if a condition was present on admission. But remember, you can never back a provider into a corner. You've got to give them an out. You must always offer options like unable to determine or other explanation to completely protect their independent medical judgment. If the clinical picture is genuinely unclear, the provider has to have the option to just say so.
As we wrap up today, think about this. Technology and automated tools are increasingly going to scan discharge summaries and flag missing words. But true clinical validation? That still requires a deep, nuanced understanding of the foundational principles we discussed today. So, how will you keep true clinical validation at the core of your practice as things evolve? Thank you so much for joining me on this explainer. Please like, share, subscribe to Decode Healthcare with Harshal.